So I'm happy to introduce Dr. Marco Vitellaro from Istituto Nazionale di Tumori in Milan. He is chief of the hereditary digestive tract tumor unit and colorectal surgery section, and initiator of the Desmoids and FAP workshop last year in Milan. And I'm really happy to have you with us. And yeah, now I would like to hand over to you.
Thank you so much. Thank you so much for inviting me and also for giving me the opportunity to talk about familial polyposis and desmoids. This is my disclosure, and just a couple of information about familial polyposis. That is an hereditary colorectal cancer syndrome, which have a risk to develop colorectal cancer between 80 and 100%. So it's something that we have to keep in mind. It's an inherited disorder leading to development of multitude of adenomas in the large bowel and also in the duodenum. Most of the patients with this condition are secondary to a germline pathogenic variant in the APC gene, but also in chronic polyposis is associated with a recessive condition with the pathogenic variants in the MUT1-IH gene. And we also decide that patients with colonic polyposis without pathogenic variant in APC or MUT1-IH gene are called non-associated APC MUT1-IH polyposis. Okay, this is how looks the colon with polyps. And about those patients, we have to say that when it's diagnosed, the surveillance starting in the early teens with colonoscopy and with a physical examination to identify the extraintestinal manifestation. There are different phenotype, so we have to consider that it's not the same for all patients. And it's really important because it's what we have to consider for the management of those patients. Here you can see the inside of the colon during the colonoscopy, and it's absolutely understand that it's not possible to manage the removal of all the adenomas from the endoscopic side. About the associated findings, we have to say that okay, we saw that it's an autosomal dominant inheritance from the an associated APC pathogenic variant, but also we have to say that 30% of patients may present a de novo mutation. It means that is not inherited from one of the parents. The possible associated findings are the congenital hypertrophy of the retinal pigmental epithelium, the osteomas, the supernumerary teeth, the odontomas, epidermoid cystis, duodenal and other small bowel adenomas, and gastric fundic gland polyps. But also there are other cancers than the colonic one. And what is really important to see is that should be this that we have to think about that between 10 and 25% of the patient is a risk to develop an intra-abdominal desmoid fibromatosis. Some key consideration that the desmoid type fibromatosis is one of the cause of mortality after total colectomy. So for patients who remove the colon to reduce the risk of colon cancer. And of course, we have to think about that there is a genotype-phenotype correlation, and it's important to manage the patients with FAP inside of collaborative group of specialists. Desmoid fibromatosis, what we have to understand in patients with FAP is that patients with FAP has like 1,000 times more likely to develop desmoids. And okay, is not metastasizing, but can be locally invasive. And the overall mortality in patients with FAP related to desmoids type fibromatosis is from 10 to 50%. Here we can see a couple of images to understand a little bit more which type of desmoid we find in patients with FAP. On the okay, you can see from the arrow a small, very small fibromatosis that is determined dilatation of the kidney pelvis. Okay. Another type of identification that we have for the intra-abdominal desmoids is a big mass like this, usually starting from the root of the mesentery. Here you see it can develop a small bowel obstruction, and will be very, very, very a big problem for the patient. Here you can see also that we can find some desmoids in the abdominal wall. Talking about the risk factors for predicting the risk to develop a desmoid type fibromatosis, we know from literature that about the gender, female patients were 1.5 times more likely to develop a desmoid. We talk about the correlation genotype-phenotype, and by the age, we know that most of the patients will develop desmoids in the second or third decades of life. Previous surgery in the abdomen increase the risk to develop desmoids, and the median post-operative time from the surgery to the developing of desmoids, it's around 3 years. Something is really also important is considering the risk related to the family history. Okay? Those are the 2 surgical options that we consider in the preventive surgery. in the one where we can save the rectum, that is the option that we support a lot. And the one where the rectum should be removed because of the number of polyps in the rectum. And this is a more complex surgery. Of course, more complex means more risk of complications. More risk of complication means more risk of desmoids. Okay, I'm a surgeon, but I love this picture because you can really understand the correlation between genotype and phenotype. So you see if the mutation is in the codon close to here, you really can predict the risk to develop a desmoids. It's a risk, it's an higher risk, and this should be known by not only the surgeons, but all the specialists that take care of the patients, because it's important also to screen the patient. So we can say that the time between the surgery and the diagnosis of desmoids is around 2-3 years. Some clinicians try to delay the time for surgery. But, you know, it's important also to consider that close to 100% of patients will develop a colorectal cancer. Laparoscopic approach, speaking about the preventive surgery, will really reduce the risk to develop a desmoids. And some studies demonstrate that there is not too much different between total colectomy and proctocolectomy about the risk to develop desmoids. Surgical approach. This is an open abdomen surgery for who is not familiar with this. This is a laparoscopic approach. Obviously, the laparoscopic is advocated to reduce the risk of desmoid. This is 10 years ago, publication from our group. We identified and we presented the first report in which the type of surgery was a risk factor for patients with desmoid. And the laparoscopic surgery was protective. Also, a little bit the total colectomy versus the proctocolectomy.
Laparoscopy is better also in the patient that have the mutation in the before you told us that there is a mutation.
Yes.
That has got higher risk.
Yes, absolutely. Yes.
And the laparoscopy is best also in that kind of mutation.
Also. Because probably it's something that we couldn't demonstrate yet, but probably something in reducing the inflammation inside the abdomen. Okay. About surveillance, the guidelines said something about intra-abdominal desmoids when it's found. But it's absolutely important to screen for desmoid. This is our numbers from 2000, the year when I joined the National Cancer Institute. There are almost 300 colectomies for familial polyposis. Obviously, here you can see the ones related to APC gene, the ones related to mutual AIH and the ones related to non-RPC mutual AIH polyposis. And the surveillance program at our institution is not only colonoscopy or upper GI scope, but also abdominal ultrasound or CT scan or MRI for patients with high risk for developing desmoids. That's why we are confident that the number of desmoids that we found is correct. And you can see it's obviously it's around 12% in our total population of only patients with the APC mutation. And what is a little bit strange for us is that the time from surgery to desmoids was between 1 and 13 years after surgery. So it means that what we were thinking about, that only the first 3-5 years could be the worst time, is not so real. And probably also sometimes far from surgery, some inflammation happen in the patients and could develop desmoids. This is, in summary, what we do for patients with familial polyposis and desmoids. But what I like to highlight for you is that when you have an high-risk biopsy, that means that the desmoids is in a very complicated area inside the abdomen with a multidisciplinary team. You can skip the biopsy and go to the therapy. I know it's not easy in a sports center, but in a center where you have all the specialists that take care of those type of patients, it's possible. In conclusion, what we have to say is that preventive colorectal surgery is mandatory for those patients. Laparoscopic approach may reduce the risk of desmoid type fibromatosis. An active surveillance, it's important, but also a screening is important for patients who did surgery. The multidisciplinary team is the key role for those type of patients. I really like to thank you and really appreciate the chance to give this presentation.
Thank you so much. So, any questions from the audience? Because otherwise I will start. You told for the follow-up, you recommend CT, MRI, and ultrasound. How do you decide what is the best for the patient? Because I heard from the surgeons that in this region it is better to have CT scans. Otherwise, I think in the younger age you have to think of the side effects of CT scans. So how do you?
So what I can tell you is that we can divide a little bit the patients with FAP in high risk for desmoid, low risk for desmoid. The high risk for desmoid are the patients with the genotype-phenotype correlation, with family history, or patients with complicated surgery. For that patients, CT scan or MRI, of course, young people could be benefit from MRI because the low dose of radiation for sure. But you also need to have a radiologic team who can really take care of these patients.
Okay.
For patients with low risk for desmoid, I really recommend a ear ultrasound, because ear ultrasound, I know that is not for a completely picture imaging, but if you have a problem with that which is running inside the abdomen, you can find and you can refer the patients to a CT scan or to an MRI, and you can go in deep of the problem. Of course, if you cannot see with the ultrasound, probably the small desmoids that we saw at the beginning of the presentation, but you can see something that is going on the kidney pelvis. And you say, wow, what is going on here? And you can say, you have a dilatation of the kidney pelvis. So do a CT scan or do MRI and we'll understand better.
Okay. Thank you.
How many patients human age with in these last 2 years?
In the last
2 years.
You means new patients. Okay, we treat for surgery at around 20 patients per year. Young adults, it means teenagers and adults, around 20 patients per year.
Okay, so it means 2 per month. Yeah.
Almost,
Okay.
almost.
Just one question.
Of course, excuse me, with all type of polyposis, because you have APC, you have mutal-H, you have a polyposis with no genetic identification yet, because of course, probably something is running, but we don't know.
If we have a patient with desmoid tumor, so it's the first diagnosis of desmoid tumor, maybe intraabdominal, and the patient didn't have a genetic analysis, but maybe only in histological exam. Sometimes they ask us, but should I do also a colonoscopy or not?
Okay.
Because I can say, no, you don't have FAP. I'm not sure about that.
Okay.
Yeah?
No, okay. I understood. We have, this is we have 2 ways to find, okay, 3 ways to find patients with polyposis: from family history, from symptoms, abdominal symptoms, or because they found desmoids. And of course, you can in pathological report, when they find a desmoids, they will go through a molecular analysis, and they can tell you if it's sporadic or could be associated with familial polyposis. They call it Gardner-associated desmoids.
But the center, for example, in Italy, hospital, because sometimes
okay, I know. That's why okay, of course, what you can say is that from Spoke Hospital, where the diagnosis of desmoids could be done, they will send to a referral center. What we are doing, I can tell you is the project for 2024. We are working to establish an Italian network for the familial polyposis. It means that, of course, it's not just for the colon surgery, because the colon surgery could be done, I can tell you, in a well and correct way in several centers. But the problem is especially for desmoid. So now we are starting. I can tell you that in Italy, it's a little bit more complicated than in Europe from the privacy part. But we are working to establish the Italian network, and we're gonna join hospitals that are referral or not referral, but when they will see patients with familial polyposis, we can discuss all together. And of course, they can do surgery, but we can also discuss the management of those patients.
Is it expected of life with patients with FAP and desmoid in Sarcoma?
I can tell you that most of the time, if the desmoids is not completely in the root of mesentery, it also could be long life, because could be a chronic disease when stop increasing, or with the use of medical treatment, you can control, and when it become a chronic disease, could be also not a problem. Just you can follow up during the time.
It depends on the position.
Depends on several problems, but the location where is the site, where is inside of the abdomen, it's absolutely important. Of course, if is in the abdominal wall, usually it's not life-threatening. Thank you so much.
More questions?
Because we have several here, 3, 4, maybe patients that diet, maybe I don't know where there is the location, but we have several patients with FAP that diet.
Yeah, but they are treated in a specialized center.
Yes, yes. We know a couple of them. Of course, it's
maybe too later to
no, also sometimes the disease run faster, and when the root of mesentery will be involved, also the vessels are involved, and this could lead to the death for vessel involvement.
But have you looked a little bit deeper in the pathology of these patients?
Okay, we have several projects that we are trying to. Of course, we are one of the projects that is Bern knows, because we were talking about in Milano, is that we are working to try to identify a path with artificial intelligence to identify the risk of desmoid inside of the abdomen, to avoid the biopsy. Of course, we are also trying to understand a little bit. It's not only from pathology. The problem is try to understand what's bring to the eye inflammation that let's start something inside of the abdomen of the patients with the FAP that lead to development of desmoids. It's complicated, but you know, because if you find because the problem that we were also talking about is that when you find the desmoid at the starting of the process and it's small, you can control, you can start treating, and then you can stop, and then you can control. When you find a big desmoids in the abdomen, it's a problem. Because it can involve the small bowel loop, and obviously could be an abscess could start, and then it's a big problem. And obvious the surgery that you can do, it's only a bypass surgery. And it's not a resolutive surgery. The resolutive surgery is something that, of course, is probably is in the future, but right now there are only small experience talking about the small bowel transplantation.
So thank you so much for the presentation. So our next speaker is Bernd Kasper. I think you all know him. He he will give us an update on the latest edition on the consensus paper.
Ale. Yes, so happy.
Yeah.
Okay, so thank you very much. And first of all, I really would like to say that I really enjoyed the very first session here with all the projects from you, because actually, I mean, we are doing these kind of meetings since 10 years, yes. More than 10 years. And by that time, it was only SOS Desmoid Germany. We had SOS Desmoid in France, and more or less that was it. And meanwhile, we have a lot of organizations from all over the world. And I think that's great to see. And that's great to see how the momentum is about this disease, not only from the medical or from the expert side, but also from the patient side. And that's something nice to see. Okay, I will try to give a bit of an update, or I will try to summarize our latest edition of the Global Consensus with a bit of a focus, of course, on the current systemic therapies, which is, of course, my special topic about that, and we'll try to summarize that. I can use this? Okay. Yeah, so just to start with a bit of history, you know that, of course, we started this initiative now more or less exactly 10 years ago in May 2014. That was our very first meeting in Frankfurt, Germany. So by that time, we met with medical experts from the ERTC soft tissue and bone sarcoma group, together with patients and patient advocates from SPAGN. That was only European based, and we were a very small group, and the idea, of course, was to harmonize the treatment recommendations only for desmoid tumor patients with sporadic disease. And we came up with this first deliverable in the European Journal of Cancer in 2015. 2 years later, we updated that in the Annals of Oncology. And you know, kann ich die auch hier sehen? And in 2018, we pushed this initiative forward within 2 aspects. So first of all, we did a systemic literature search, which was done by an institute in Germany. That was actually the same institute where we also did our national guideline in Germany. And secondly, and this is maybe even more important, is that the group really went global. So we included and invited our friends and experts and patient groups from more or less all over the world, from US, Canada, Asia, and that's the way how we did that. The next, yeah, and that was then these are different. That's interesting to see. So when when you do this. Okay, and this was the deliverable from that 2018 meeting that with a global evidence-based desmoid consensus guideline published in the European Journal of Cancer in early 2020. Okay, for the meeting last year then, that was 5 years later, we thought it is definitely time for an update. We have the new therapies and we have new local therapies or more data in local therapies. So we came up with the idea to update this consensus. We started with a kickoff meeting in Vancouver at the CTOS meeting in November 2022. We again performed a literature search, but not in that, not that big as we did for the first meeting. We only focused on the systemic therapies and on the big trials for the systemic therapies. We drafted a paper within smaller working groups. Marco was involved in that as well for the FAP part. And that was actually the basis for the meeting in Milan in June last year. And currently we finalized the publications. And leave it. I will just do it there.
Yeah, okay.
Okay, and we did a literature search, but only for the randomized trials for systemic therapies, because for all the other stuff, there were not so many new publications, so it was not actually necessary to do a really evidence-based literature search. And stell's wieder um.
Yeah, it's not too much fun.
Yeah.
I think it's now working. So.
Yeah, and we actually focused on what we called the hot topics. We only had one day. So we looked at the positioning of local therapies, where the systemic, when choosing systemic therapies, is there a first-line therapy? What are the remaining indications for surgery and radiotherapy? We had, and that was also very new in this edition of the guideline. We had much more space and a much bigger section for two specific patient populations, for the FAP patients and also for the pediatric patients. Of course, we also covered the quality of life and benefit part. Oops. And updated the overall treatment recommendations. And what I would like to do now is share with you more or less the main consensus statements for each of these topics. For the positioning of local therapies, cryoablation currently appears as a promising local treatment option for desmoid tumors. We have only one prospective trial, that is the Cryo-Desmo-1 trial at the moment. And according to this trial, the current indication for cryotherapy is a growing desmoid tumor after at least 2 lines of medical therapy or with functional symptoms or pain. Of course, a multidisciplinary discussion is necessary, and you always have to keep in mind that cryotherapy is, of course, not available in every center, in every country, and does require a very special expertise from an interventional radiology team. Randomized studies are, of course, encouraged. Okay. For the available systemic therapies, we do have randomized phase 3 data only for 2 drugs. That is actually sorafenib and most recently for nirogacestat. And meanwhile, nirogacestat is the first approved drug in this disease indication. And so I would like to focus a bit more on these 2 substances. The sorafenib trial was published in 2018. Very prominently in the New England Journal of Medicine. That was the first ever randomized phase 3 trial that was done in desmoid tumors. And as you can imagine, sorafenib was beneficial for the patients with a longer progression-free survival. The response rate that was very interesting was 33% for sorafenib, but was also 20% for the placebo arm, which very nicely reflects the natural biology of this disease. And then, of course, the second compound is the gamma secretase inhibitor nirogacestat. I had the privilege to present this phase 3 trial at the presidential session at the ESMO meeting 2022 in Paris. And I would like to summarize a bit again the results of this trial. That was a phase 3 trial, placebo-controlled trial. 142 patients were randomized across 37 sites in North America and Europe. It was a comparison nirogacestat compared to placebo with a primary endpoint progression-free survival. And the secondary endpoints were objective response rate and a couple of different patient-reported or patient-relevant endpoints, including pain, symptom severity, physical role functioning, and overall quality of life. So these are the patient demographics. As you can imagine, that it is a young patient population, median age 34 years. We had with a female predominance of about 2/3, which also is very nicely in line with the natural biology. We had about 25% intra-abdominal and 75% extra-abdominal tumor locations. And we had a quite high percentage of patients with multifocal disease. That was around 40% in both arms. And of course, a lot of pre-treatments. So this was the primary endpoint, a very nice Kaplan-Meier curve. Nirogacestat significantly reduced the risk of disease progression by 71%. So hazard ratio 0.29. The median progression-free survival in the placebo arm was 15 months and was not even reached for nirogacestat due to the low number of events. This is the objective response rate. That was 41% for nirogacestat compared to only 8% in the placebo arm. And we had 7% complete responses with nirogacestat. What is also important to mention that nirogacestat works quite rapidly. So the time to response to an objective response was around 5 months in the nirogacestat arm and was almost doubled in the placebo arm. So not only looking at these size measures, PFS and overall response rate, maybe the even more important things in this study were all the quality of life data that were captured. And I just show you this one. This is the one showing that nirogacestat significantly reduced the desmoid tumor-specific symptom severity. This was actually measured by a very specifically developed tool, the so-called Goddess score. And you can see a clear improvement in favor of nirogacestat. But all the other things and all the other patient-reported outcomes, pain, role, physical functioning, overall quality of life, they were all statistically significant improvements in favor of nirogacestat. So what about the side effects? These are the main side effects with nirogacestat. It's diarrhea, nausea, fatigue, hypophosphatemia, and rash. However, 95% of these, what we call treatment emergent adverse events, were grade 1 or 2. And most of these events occur very early, so usually during the first cycle of therapy. And then, of course, you know about this ovarian toxicity, which is something which is actually not specific to these gamma secretase inhibitors. This is something we observe with a lot of other oncology medications as well. But in this study, actually, we studied it in very much detail. So overall, 75% of the females of reproductive potential complained about or described any kind of symptoms of ovarian toxicity. However, for the 11 patients where we stopped nirogacestat for any reason, so we had a 100% resolution of these symptoms. And for the 14 patients who continued with the drug with nirogacestat, the overall resolution of these ovarian toxicity was in 2/3, so 64%. So we published that study very prominently last year, then in March, in the in the New England Journal of Medicine, and this is maybe even more important, of course, this led to the first approval of a drug in this indication. So nirogacestat is now approved for adult patients with a progressing desmoid. This is important. It has to be a progressing desmoid tumor who requires systemic treatment. Okay, coming back to the consensus statements, as I said, sorafenib and nirogacestat are the only two drugs where we have phase 3 data. However, we do not have comparative studies. So this is the reason why we, as the consensus group, did not actually give a recommendation regarding the definitive sequence of the existing systemic treatments. So when it comes to the selection of therapies, you always have to look at the patient situation. Of course, you have to look at the unique toxicity profiles of all these individual agents. But I mean, for us as physicians and also for the patients, the richer the armamentarium is, the better it is, of course, and it allows you to have multiple choices for each clinical scenario. Of course, one very open question, it remains an open question, is the duration of therapy, which, of course, neither the sorafenib trial nor the nirogacestat trial somehow answered. But what we actually consented in the group is we said at least a treatment of between 6 to 12 months is required to really assess the efficacy of any kind of treatment. What about the remaining indications for surgery? You all know that there has been a paradigm shift from very extensive surgeries 10, 15, 20 years ago. This has completely changed. So surgery is no longer the first-line treatment for this disease. However, when it comes to complications such as bleeding, obstruction, or perforation, of course, surgery still plays a critical role. However, the goal in this situation is not to achieve an R0 resection, but you would like so the goal is to actually treat the complication and to reduce the morbidity. In case there is a progression on medical treatment or surveillance, again, surgery may play a role, but you always have to take into account the possible morbidity, of course. If you have, and that is often the case, we see patients and they are previously treated with any kind of surgery. However, if you see a patient with a previous margin positive, either a R1 or R2 resection, that doesn't mean that you have to do an immediate re-resection, nor radiotherapy. So again, you should actually watch and wait and just control the patients. After prolonged medical treatments, having achieved a stabilization, again, active surveillance is the way to go. Radiotherapy doesn't play a very big role anymore. So for patients with progressive and/or symptomatic disease who are candidates for systemic therapy or whose disease is refractory to systemic therapy, local therapies, including radiotherapy, may be still considered. So radiotherapy is maybe the preferred modality for a desmoid tumor, which is too large for cryoablation, or for which surgery would be associated with a just unacceptable morbidity. And what is also important, radiation is not indicated as any kind of adjuvant therapy after surgery. After surgery. Approach in pediatric patients, as I already mentioned, that we had a lot of medical experts from the pediatric field, and more or less the recommendations are the same. An initial observation is recommended at the very first diagnosis. Tumor resections should be avoided, and the kind of first-line therapy is a bit different in the pediatric population. So there, a weekly intravenous methotrexate vinblastine regimen is the kind of first-line therapy. Alternatively, you can also use oral vinorelbine or you can use a tyrosine kinase inhibitor. But we do not have very many data on tyrosine kinase inhibitor in pediatric patients, so we only have a bit of data in adolescents. The use of gamma secretase inhibitors should be delayed in this patient group until we have the results of the ongoing trial. The ongoing trial is actually finally recruited, but I think we will have the data of that trial early next year. Again, the duration of medical therapies, we do not have a very hard data on that as well. But again, we recommended a duration of therapy of at least 6 to 12 months. I left out FAP because that was covered already in your talk excellently. So last but not least, to measure the quality of life and benefit is of course important in this patient population. It is important to offer these patients an interdisciplinary supportive care because desmoids can have a major impact on patients' life, their social interaction, their ability to work and relationships. So the treatment on the management of these patients should always be a personalized and collaborative one, including pain specialists, physiotherapists, psychologists, and social workers. Last but not least, what we also did, we updated the treatment recommendations, and this is just one example I would like to show you. This is the one from first diagnosis to the treatment indication. I just want to highlight here that, of course, in the majority of the patients, the frontline approach still is active surveillance, and only in the case of subsequent progressions, we really go for a specific kind of treatment. And yeah, this is the group with whom we met in Milan in June last year. These, I think we were around 50, 60 people on site. We had a couple of other people joining online. And overall, the group is now almost 100 people. And we were able to not yet publish, but we send it in the manuscript to JAMA Oncology, and they finally accepted it. And yeah, I think it will be out in a couple of months. And of course, this is really a great achievement. So thank you very much for your attention. And I especially would like to thank Alex Cronky, of course, with whom I'm pushing forward this initiative now for, I think, these 10 years. Yes, thank you very much.
Good.
Any questions?
Question, even with the chemotherapy for adult people, you did, as far as I've understood, you don't mention it anymore.
No, I didn't. So here I just focused on the nirogacestat and sorafenib. These are the two compounds with let's say the highest evidence, because all the chemotherapy we do have a bit of evidence, but we do not really have randomized trials or very good data. But yes, still chemotherapy is in the treatment armamentarium, but I would say it is reserved to situations where we really need a rapid response in really fast-growing, life-threatening situations. Then we still go for chemotherapy. For example, we in Germany very often use liposomal doxorubicin Calyx, which is better tolerated and than doxorubicin. And but you can also, of course, use the methotrexate vinblastine. You can also use it in adults. It's the standard of care in pediatric patients, but you can also use it in adults. So the Italians have a lot of data on that.
Yeah, usually we have not the sorafenib for.
Yes, a few is registered for sarcoma.
Yeah.
For Desmoids tumor.
Yeah, the availability of these drugs is a big problem, and this is different all over the world. For example, in Japan, they use pazopanib because pazopanib is approved for sarcomas, and so they can also use it for desmoids. But in a lot of countries in Europe, sorafenib, as it is not formally approved for this indication, cannot be used. We in Germany are quite lucky. We can prescribe it and we can use it, and it's usually paid by the insurance. But it's of course not formally approved. That's a bit the problem. And that's a problem in a lot of other countries in Europe as well. But to be honest, I believe this will also be a problem with nirogacestat, because even if nirogacestat is approved by the EMA in Europe, it still has to go through all the different country national legislations. And to be honest, with a price of $29,000 per month, $29,000 per month is the price in the US at the moment. It will be difficult in Europe to, I mean, of course, the price will be, it is for a non-cancerous, usually non-life-threatening disease. So it will be, I mean, the price will be different in Europe, I'm sure. But anyway, it will be a high price. And so this will be, for example, for UK, I think it's unbelievable to get it ever approved within their system. For Germany, I don't know. It will also be difficult. And we will see.
When do you think the EMA?
I mean, so it was filed by the EMA in February, so they are reviewing it now, and I think there will be a decision this year. Yeah, but then it goes to the national.
So this year for EMA. So
for
yeah,
EMA, yes.
Okay.
But and I mean, we know this problem from a lot of other therapies as well. I mean, for example, for GIST, we have ripretinib, which is also approved by the EMA, but is available only in very few European countries.
So that's for other, in the Netherlands, we had recently a whole problem for breast cancer medicine. So even for cancers.
So in this respect, it is important to have the quality of life data. And this is the very good thing about that study, about the DeFi study. It has a really big bunch of quality of life data. And the second important thing is you, the patient advocacy groups. And so you really have to put a lot of pressure on your national.
We have to organize them together.
Yeah, but
It's
it's
also
also
on
on
a
national,
national-
it's on a
But
national
do you
level.
think that we can be
Yes, I know.
used also for
To-
MAA or for our national?
I mean, for the EMA review, they usually invite people to and they usually also invite patients or patient advocates and for the review process. But yeah, I mean, then it goes to the national, and this is the difficult thing.
The difficulty is also because we don't know the duration of the therapy now.
Yeah.
It costs so much, but we don't know for how much time the
Yeah.
patient has to
But I
be-
can at least disclose that I mean, SpringWorks is very much interested to gain more data on two things: on the ovarian toxicity issue and also on the duration of treatment. So we are currently in discussion to set up a clinical trial looking more or less at these two aspects, maybe within one trial. So only involving female patients, looking at the ovarian toxicity things, and do a kind of discontinuation trial, let's say after 1 year or 1.5 or 2 years, stop the drug and see how it goes.
Something about the other clinical studies, like
AL102, yeah. I mean, that's.
We lost all of information. We don't have to do it.
Yeah, I mean that's.
You know,
Yeah. So there's actually, I didn't show that, but there is another gamma secretase inhibitor currently tested, which is called AL102 from Ayala. It's a company from Israel, and this trial is more or less the same as the DeFi trial, in at least the randomized part, and it finalized recruitment in February, March. So with 100, yeah, and now we just follow up the patients. So I think we will have data maybe early next year, or yeah.
And I think the company name changed, or they were bought by
Yeah,
a company.
I mean, you can imagine for a company in Israel, the situation is not so easy at the moment. Yeah, so they are already, they gave the truck to another company. Which already took over, and yeah, but the trial is ongoing. We also participated in that trial, and it looks like it is pretty similar. It is so the side effects are very similar. And it works very well as well.
The time of
Yeah.
the time of clinical trial.
Yeah.
In this time.
Yeah.
At what point?
Yeah, but I mean, you have to be careful for the DeFi study. It also took a bit longer at the end until we had the events. So it took much longer than we expected at the end. But yeah, let's see.
Okay, thank you.
Just a note, there's not a break right now. We're going directly back to the auditorium for the final session. We're going to be meeting the winners of this year's Advocacy and Action Awards. So,
Deswegen habe ich ja gesagt, das ist, ja. Und da stimmt irgendwas mit der Technik, das hat mit den anderen zu tun.